Hello, and welcome to the June 2024 HRO2 podcast. I'm Jeanne E. Poole, the editor-in-chief. We have 11 articles publishing in this issue. The first is titled Safety of Outpatient Commencement of Sotalol by Dr. Soraya Kamzani. The purpose of this study was to assess the safety of outpatient sotalol initiation. This is a multi-center retrospective observational study of 880 consecutive patients who have started sotalol as an outpatient. ECGs were obtained at 3 days, 7 days, and 1 month. The arrhythmia was atrial fibrillation at 87.3% and ventricular arrhythmias in 9.9%, and other arrhythmias in the remaining 2.8%. The initiation dose started low with a daily dose of 131 milligrams per day. The QTC interval baseline was 431 milliseconds and increased to 444 milliseconds on day 3 and 440 milliseconds on day 7 with a significant p-value. Sotalol was discontinued in 4 patients in the first week due to QT prolongation, and 1 patient had the dose reduced. 3 further patients had dose reduction due to bradycardia and 3 others for dyspnea. Only 1.1% of the patients developed a QTC greater than 500 milliseconds or greater than 25% increase from baseline. 4 of those occurred within the first 3 days, 1 within a week, and 4 within 60 days, and 1 after 3 years of use. No ventricular arrhythmia, syncope, or death was observed during the first week. Discontinuation of sotalol due to other side effects occurred in 41 patients within the first month of therapy. The authors conclude that sotalol initiation in the outpatient setting with a specific protocol can be used and performed safely. Very few patients had significant QT prolongation. The next paper is titled Symptoms of Gastroesophageal Reflux Disease Predicts Low Voltage Zones in the Posterior Inferior Left Atrium in Patients with Persistent Atrial Fibrillation. This is by Dr. Astrid Paul Norden. The purpose of this study was to investigate if gastroesophageal reflux or GERD predicts the presence of low voltage areas in the posterior inferior left atrial wall. As background, the authors note that the presence of low voltage zones in the left atrium is associated with the recurrence of atrial fibrillation after pulmonary vein isolation, and that numerous studies have suggested a link between GERD and AF due to the anatomical proximity of the esophagus to the posterior inferior wall of the left atrium. The authors looked at 551 prospectively enrolled patients with persistent or long-standing persistent AF undergoing first-time catheter ablation. Voltage maps were collected using a multipolar catheter, and low voltage zones were defined as areas measuring 3 centimeters square with a peak-to-peak bipolar voltage of less than 0.5 millivolts. The documentation of a history of GERD was collected from the participants through a self-administered questionnaire. The patient population included long-standing persistent AF in 22.3% of the total cohort, and the remainder had persistent AF. GERD was present in 29% of the patients. Low voltage zones in the posterior inferior wall were found in 12.7% of the patients. Following multivariable analysis, patients with GERD had a greater than 2-fold odds of having low voltage zones in the posterior inferior wall of the left atrium compared with patients without GERD. Having GERD was not associated with low voltage zones in any of the other regions of the left atrium. The authors conclude in this interesting study that GERD was found to be independently associated with low voltage zones in the posterior inferior left atrium, and they posit potential local inflammation of the esophagus as the explanation. Next up is a paper titled Short-Term Safety and Feasibility of a Practical Approach to Combine Atrial and Ventricular Physiologic Pacing, an initial single-center experience by Dr. Kita Watanabe. The purpose of this study is to examine feasibility, efficacy, and safety of anatomically guided high right atrial septal pacing with activation of the Bachman's bundle, combined with routine left bundle branch area pacing. The background of this study is that traditional right atrial appendage pacing accentuates interatrial conduction delay. This has been shown to have an association with atrial arrhythmias over time. The authors also suggest that a high right atrial septal position will be safer and less likely to result in leaf perforation, especially in the elderly. This was a retrospective single-center study of 96 consecutive patients who had physiologic pacing in 32 that included high right atrial septal position and left bundle branch area pacing position for the lead positions. And the second group was a group of conventional pacing patients and 64 patients who had traditional right atrial appendage and right ventricular apical lead positions. The atrial lead was implanted in the high right atrial septum targeting Bachman's bundle. The ventricular lead was implanted in the left bundle branch area. The control cohort of 64 consecutive patients were all identified if they had had right atrial appendage and right ventricular apical lead placements. Baseline characteristics, sensing, pacing thresholds, and impedances were recorded at implantation and follow-up. The average age was 74 years, with 28% women in the physiologic pacing group and 41% in the traditional approach. These differences were not significant. Procedure was conducted in 95 minutes in the left bundle branch area and high right atrial septal pacing group, and 87 minutes in the traditional lead approach. There were no differences in fluoroscopy time. The patients who had high right atrial septal pacing had higher atrial pacing thresholds, 1.5 millivolts versus 0.8 millivolts, and lower P wave amplitudes, 1.8 millivolts versus 3.8 millivolts at implantation. Similar differences were noted at follow-up. In the physiologic pacing cohort, 72% of implants met the criteria for left bundle branch pacing, and 94% of which demonstrated left bundle branch area pacing. One lead-related complication occurred in each group. One in the physiologic pacing group was a sudden change in threshold 2 weeks later without X-ray or echo changes. The other lead complication occurred in the control group, where a new pericardial effusion was identified 6 days later, requiring evacuation. In both instances, the leads were repositioned. The authors conclude that in this feasibility study, routine placement of leads in the high right atrial septum is feasible and a safe alternative to standard right atrial appendage pacing, and suggests that high right atrial septal pacing can be considered when performing left bundle branch area pacing. The title of the next paper is Efficacy and Safety of Implantable Cardioverter Defibrillator Implantation in the Elderly, the I-70 Study, a randomized clinical trial by Dr. Stephen Singh. The background for this paper, as stated by the authors, is that there is conflicting evidence on the efficacy of primary prevention implantable cardioverter defibrillator implantation in the elderly. The purpose of this study was to determine the efficacy and safety of ICD implantation in patients 70 years and older. 167 patients that were equal to or greater than 70 years participated in this study. They had to be eligible for regular ICD implantation according to guidelines, and they were randomly assigned 1-to-1 to receive either optimal medical therapy, 85 patients, or optimal medical therapy plus an ICD, 82 patients. The mean age of the patient population was 76 years, and nearly 100% were male. 144 patients, or 86.6%, completed the study protocol according to their assigned treatment group. The average participant follow-up was 31.5 months. GDMT was reasonable at targets of 90% for ACEs, and for beta blocker therapy, use of ARNIs or SGLT2 inhibitors was not documented and presumptively not used. Mortality was similar between the two groups. 27 deaths in the optimal medical therapy, or 32%, versus 26 deaths in the ICD group, or 32%. There was a trend favoring the ICD over the first 36 months of follow-up. Rates of sudden death were 26% in the optimal medical therapy group and 19% in the ICD group. This was not statistically significantly different. Also, all-cause hospitalization was not different between the two groups. 11 participants randomized to ICD therapy received appropriate therapy for VT or VF. 5 participants received an inappropriate therapy that included at least one ICD shock. As the authors note, the study was significantly underpowered to demonstrate the estimated 25% risk reduction in mortality. I think it's important to acknowledge that both all-cause and sudden death mortality have drastically dropped in the contemporary era, and it will be difficult to power randomized trials of ICD effect for all-cause mortality. In this study, however, the mortality was fairly high, but not different between the two groups, and reflective of the overall total mortality and non-sudden death mortality in older ages. In addition, the sudden cardiac death mortality was 26% in the optimal medical therapy, and 19% in the ICD group over about 2.5 years of follow-up for the entire population. That is actually quite high and similar to the Scud-Heft era and MADE-2 era ICD trials, but there was no significant difference. This may also reflect the difficulty in assigning cause of death. As the authors note, larger trials would need to be conducted to understand the benefit of ICD therapy in individuals greater than 70 years, and I would add also that such trials should enroll 50% women. The next paper is titled Posterior Wall Ablation for Persistent Atrial Fibrillation, Very High Power, Short Duration versus Standard Power Radiofrequency Ablation by Dr. Paolo Campanucci. The purpose of this study, as stated by the authors, was to compare PVI plus posterior wall ablation using very high power, short duration versus standard power ablation index-guided catheter ablation amongst consecutive patients with persistent atrial fibrillation and to determine the voltage correlation between microbipolar and bipolar mapping in AF. The study includes 40 patients undergoing PVI plus posterior wall ablation, or PWA, using the very high power short duration, to 40 controls undergoing the same planned procedure but using standard power. The primary efficacy endpoint was recurrence of atrial tachyarrhythmias after a 3-month blanking period. The primary safety outcome was a composite of major complications within 30 days after catheter ablation. In the very high power group, high-density mapping of the posterior wall was performed using a multipolar catheter and microelectrodes located on the tip of the ablation catheter. The authors note that PVI was more commonly obtained with the high-power short duration compared to the standard power ablation, 98% versus 75% with a significant p-value, and this was despite shorter procedural and fluoroscopy times. Survival free from recurrent atrial tachyarrhythmias at 18 months was 68% in the very high power short duration group and 47% in the standard power group. No major adverse events occurred. Multivariate analysis showed that the very high power short duration approach was significantly associated with a reduced risk of recurrent atrial fibrillation with a hazard ratio of 0.39. Microbipolar voltage cutoffs of 0.71 and 1.69 millivolts predicted minimum bipolar values of 0.16 and 0.31 millivolts in AF respectively, with accuracies of 0.67 and 0.88. The authors conclude that very high power, short duration posterior wall ablation plus PVI may be faster and as safe as standard power catheter ablation amongst patients with persistent atrial fibrillation with a trend for superior efficacy. The authors recommend that adaptive voltage cutoffs should be used for identifying atrial low voltage areas with microbipolar mapping. The title of the next paper is Pulsed Field Ablation versus Thermal Ablation for Atrial Fibrillation, a Meta-Analysis by Maria Clara Azibas de Campos. The background for this study is that pulsed field ablation is an alternative to thermal ablation in patients with atrial fibrillation receiving catheter-based therapy for pulmonary vein isolation. However, its efficacy and safety have yet to be fully elucidated. The purpose of the study was to compare the acute and long-term efficacies and safeties of PFA and thermal ablation. The authors performed a systematic review and meta-analysis of randomized and non-randomized controlled trials comparing PFA and thermal ablation in patients with AF undergoing their first PVI ablation. The thermal ablation group was divided into cryoballoon and radiofrequency subgroups. AF patients were divided into paroxysmal atrial fibrillation and persistent atrial fibrillation subgroups for further analysis. 18 studies involving 4,998 patients, 35.2% who received PFA, were included. 2 randomized trials and 16 prospective or retrospective studies make up this group of studies. The clinical characteristics were similar between the randomized and non-randomized studies with a median age of 64 years. 62.5% were male, LVEF was 56.6%, median CHA2DS2-VASc score was 2.2, and PAF was present in 66.2%. 35.2% of the patients underwent PAF, while 64.8% underwent thermal ablation. Less than 15% of the patients were enrolled in the 2 randomized trials. Concerning acute success rates, there was no statistically significant difference between PFA and thermal ablation in terms of initial PVI success. But there was a significant difference in the rate of first-shot PVI with an odds ratio of 6.82 favoring PFA. These results were unchanged, omitting the largest randomized clinical trial and thereby decreasing the heterogeneity. All studies that compared PFA to thermal ablation reported a 100% PVI isolation. Overall, PFA was associated with a shorter procedure time, but longer fluoroscopy time. PFA was also associated with lower periesophageal injury rates with an odds ratio of 0.17 and higher tamponade rates with an odds ratio of 2.98. In efficacy assessment, PFA was associated with a better first-pass isolation rate and a lower treatment failure rate. Subgroup analyses showed no differences between persistent AF and PAF. Cryoballoon ablation time was related to higher periesophageal injury and lower PVI acute success, and procedural time. The key findings that the authors note are: first, pulse field ablation procedures were shorter than thermal ablation procedures, but fluoroscopy time was longer in PFA procedures. Second, PFA was related to a significantly lower treatment failure rate compared to thermal ablation. No significant differences were observed in less than 1 year and greater than 1 year follow-up subgroup analyses. Third, PFA was related to higher rates of tamponade and lower rates of periesophageal and esophageal injuries. No significant differences were observed regarding overall peri-procedural complications between groups. And finally, in subgroup analysis, there was no significant difference in efficacy and safety outcomes between patients with paroxysmal atrial fibrillation or persistent atrial fibrillation. However, the cryoballoon subgroup was related to all periesophageal injuries of the thermal ablation group, but with shorter procedural time compared to the radiofrequency ablation group. The next paper's title is Skin Sympathetic Nerve Activity and ST Segment Depression in Women by Sanjana Borle. The authors note that ST depression can occur on stress tests and ECGs in the absence of myocardial ischemia. They explore skin sympathetic nerve activity in 29 women, 19 of whom were healthy, and 6 who had a history of Takotsubo cardiomyopathy, and 4 with ischemia without obstructive coronary artery disease, or INOCA. The objective of the study sought to test the hypothesis that the magnitudes of skin sympathetic nerve activity, or SKNA, correlate negatively with the ST segment height in ambulatory participants. The authors used new ECG, that's NEU ECG, which is simultaneous recording of SKNA and ECGs, in order to measure the ambulatory ST height and average SKNA. All participants were provided a commercially available ECG monitor, which was placed vertically on the patient's sternum for continuous ambulatory recording for 7 days. An ischemic episode was defined as at least 30 seconds of horizontal or downsloping ST segment depression of 0.5 millimeters when measured 80 milliseconds after the J point. The cardiologist manually verified all ischemic episodes. The authors found that baseline ASKNA was similar between healthy women with Takotsubo cardiomyopathy, and women with INOCA. The authors found that the healthy women had only asymptomatic upsloping ST depression. And second, that all participants had a significant p-value less than 0.05 negative correlation between ST height and ASKNA. Third, ischemic episodes, which were a total of 15, were identified in 2 of the Takotsubo cardiomyopathy patients and 4 INOCA participants. The ischemic ST depression was associated with increased heart rate and elevated ASKNA compared with baseline. An analysis of SKNA burst patterns at similar heart rates revealed that SKNA total burst area was significantly higher during ischemic episodes than non-ischemic episodes in both the Takotsubo cardiomyopathy patients and the INOCA participants. The authors conclude that asymptomatic ST depression in ambulatory women is associated with elevated SKNA, and that heightened ASKNA is also noted during ischemic ST depression in women with Takotsubo cardiomyopathy and INOCA. The authors suggest that ST segment depression is a physiologic response to heightened sympathetic tone, but may be aggravated by myocardial ischemia. The next paper is a review topic. The title is Mechanisms of Action Behind the Protective Effects of Proactive Esophageal Cooling During Radiofrequency Catheter Ablation in the Left Atrium by Dr. Samuel Omotoya. This is really a great paper that covers this topic. I'll just read to you the following, which is taken from the author's introduction, where it is described that the evidence behind proactive esophageal cooling and the potential mechanisms of action will be discussed. This includes examination of mechanisms identified from burn, gastrointestinal, and critical care literature. The authors further discuss the relationship of these established maladaptive mechanisms to the well-recognized post-ablation pathophysiologic effects following radiofrequency ablation, and they review additional important considerations such as patient selection and usage strategies for proactive esophageal cooling. The next paper is a brief report. The title is Significance of J-Waves in Unexplained Ventricular Fibrillation Among Elderly Populations with Various Comorbidities by Dr. Naoya Kataoka. The authors note as background that the presence of J-waves in surface electrocardiograms have been identified as a marker associated with idiopathic VF in young to middle-aged healthy individuals without any underlying diseases. However, they also note that recent invasive electrophysiologic studies have demonstrated that the etiology of the J wave can be attributed to structural abnormalities and is involved in the maintenance of VF instead of just the occurrence of VF. To explore this, the authors examined 77 patients with unexplained cardiac arrest between 2014 and 2024 who were in the chronic phase of stable underlying diseases and had precardiac arrest ECGs. The authors found that J waves, defined according to current accepted definitions, were observed in 36 or 47% of the subjects in the inferior lateral and right precordial leads. The median maximum amplitude of the J wave was 0.15 millivolts. The most frequently observed J point abnormality was a J wave without ST elevation in 53%, but characterized by a notched end of the QRS waveform. The least observed J point abnormality was a slurred QRS downstroke without ST elevation in 17%. The authors find that after adjusting for clinical characteristics that a slow heart rate and the presence of J waves were independently correlated with the onset of VF. They also found that J waves were more likely to occur together with a shorter QT interval. The authors conclude that pre-existing J waves were associated with VF in cases of unexplained cardiopulmonary arrest. And this was true even in elderly individuals with underlying comorbidities. The next paper is a Fellows Corner case report titled Restoring Sinus Rhythm in a Patient with Atrial Flutter and Left Ventricular Assist Device, Does It Really Matter? By Dr. Ezzedine Fatima. The final paper is a research letter. The title is Atrial Ventricular and Sinus Node Dysfunction in Mild COVID-19 Disease, a Case Series by Dr. Andrea Suraboa. The authors describe 8 patients who developed atrial ventricular and sinus node disturbances during acute COVID-19 infection. They discuss the cardiovascular complications, specifically the risk of cardiac arrhythmias. This ends the June 2024 HRO2 podcast, and I welcome you to listen next month when the July issue is released. Thank you for listening.